Good afternoon and welcome to today's St Vincent's Foundation webinar. My name is Sue Parks and I'm the very new CEO of St Vincent's Foundation. Firstly, I'd like to acknowledge the traditional custodians of the land we're meeting on, all of the members of the Kulin Nation. I wish to acknowledge and respect their continuing culture and connections to the land. I would also like to acknowledge and welcome any Aboriginal and Torres Strait Islander peoples who may be attending today's event. I'd like to begin by introducing myself for a minute. I've very recently joined St Vincent's Foundation team and I'm absolutely thrilled to be here. I've worked as a philanthropy executive for 30 years with some of Australia's leading not-for-profit organisations. Some good, some bad. Not just in the health sector, but always with a social justice focus and the desire to make a difference myself and to lead others on the remarkable philanthropic journey. Most recently, I was Foundation Director at Cabrini Health and worked on the capital campaign there, raising $40 million for the Gandel Wing and increasing annual revenue from $2 million to $14 million. I've been at St Vincent's for 2 weeks and every day is an adventure. Every day I'm impressed by the incredible work being undertaken here at St Vincent's, both the private and public hospitals.
And what video have I got?
I've also discovered that St Vincent's has a rich history of philanthropy dating back to its early days with the sisters when they arrived in 1889. I can only imagine what they were like, 5 tenacious sisters arriving in Melbourne from Ireland, industrious, hardworking women setting about running events and even rattling tins at Flinders Street Station to raise enough money to see their goal become a reality. And here we are now. We've come such a long way, and I'm very proud to say that the focus at St Vincent's has not wavered. Renowned for a caring culture, it's clear that St Vincent's staff not only consistently deliver excellent clinical care, but they also provide all their patients with an exceptional level of compassion that is second to none. There's certainly no shortage of stories to highlight the ways our staff strive for brilliance, as you will hear from today's presentations. It's through these stories that we aim to inspire our patients, families, and our community to support the outstanding work of our clinicians, nurses, and researchers. It's thanks to the generous support of individuals, community groups, staff, and businesses that we're able to fund new equipment, infrastructure, research, innovation, and improved patient healthcare, as well as provide training for our next generation of medical staff. We support a program of nursing scholarships. As a principal tertiary hospital in the state, St Vincent's is renowned for nurturing the future leaders of medicine. We educate tomorrow's healthcare leaders to tackle the most complex problems facing our patients and health systems today. Each year, approximately 80 nurses undertake postgraduate study across a wide spectrum of specialties. St Vincent's strives to support its nurses with scholarships, and we actively support supporters for this program. Please don't hesitate to contact the Foundation if you'd like to find out more about how you can support the scholarship program. Another way that we support St Vincent's work is by offering people the opportunity to leave a gift in their will. A gift in the will provides a lasting legacy without impacting current needs of our donors. Your generosity allows St Vincent's to fund treatment, research, or purchase specialised equipment. It enables us to continue to provide the highest level of patient care that would otherwise be impossible without this vital support. And what a wonderful way to ensure your generosity makes a significant difference beyond your lifetime. If you enjoyed today's webinar, as I'm sure you will, we would be extremely grateful if you could make a donation, however large or small, to support our work. Just head to the St Vincent's Foundation website and you can find out how. And now just a bit of housekeeping. The Foundation's Robert Nash is moderating today's session. Thank you to everyone who submitted questions when you registered. Any of these questions that aren't addressed throughout the presentation will be answered at the end. You can also submit a question anytime during the session via the Q&A box at the bottom of your screen. And finally, we're recording this session, so you'll be able to watch it again or share it with your family and friends. We'll send you a link later this week. Before I introduce our first speaker, I have some exciting Foundation news to share with you. We're now into the 2021 and we're on social media. Just last week, we launched Facebook, Instagram, LinkedIn channels. We'd love it if you could join us. By liking or following our pages, we'll be able to share all the news, exciting updates, photos and videos from St Vincent's Foundation, St Vincent's Hospitals and other centres with you. It's an exciting time to be following the work that we're doing at the Foundation. As many of you know, we're working on 2 large capital campaigns. So please, I encourage you to spread the word by sharing these links with your colleagues, friends and families. Keep an eye out for the links to join our new social communities in the email you receive after today's webinar. And now I'd like to introduce our first presenter, Dr. Andrew Newcombe, who is Director of Cardiothoracic Surgery at St Vincent's Private Hospital, Melbourne. Over to you, Andrew.
Thanks very much, Sue, and thanks for the good work of the guys in the foundation organising this. So I'll just share my screen and we'll get this started. Today, I would like to talk to you about some robotic heart surgery that we've been very excited and privileged to be a part of at St Vincent's Private Hospital so far. I didn't want to get too bogged down in the detail and didn't think anyone would appreciate me showing a lot of operative videos and things like that. So I've kept it all fairly hopefully tame, but do look away if any of the photos aren't to your liking. So cardiac surgery has been around for just under 100 years in various forms, with people starting with traumatic injuries to the heart and with congenital defects, and slowly into some closed heart valvular procedures where people would make what we call a purse string suture and place fingers or instruments inside the heart without any vision and without the use of the heart-lung machine. And that invention started in the 50s, or became available to us in the 50s, and there are a few different teams that developed different heart-lung machines, and in particular the mechanism that oxygenated the blood. And that allowed us to have our first open heart procedures in the mid to late 50s. And the first open heart procedure at the Alfred Hospital, in Australia, was done at the Alfred Hospital in 1957. And that was followed a few years later by St Vincent's first open heart case by John Clareborough and his team in 1963. So a lot of the information I got from the historic events around heart surgery are from these 2 books. And one of them you can see is by one of our alumni, Kerry Breen, and he very kindly gifted this to me just in the last month because he's only just finished writing this 10,000 heart operations book. And this other one here is about some of the surgeons, Walt Lillehei in particular, who commenced heart surgery in the US and invented the heart-lung machine over there. So we see robots everywhere in our day-to-day lives and in everything that we do. And there are different versions of robots. The one that's just floated in on the left-hand side of the screen is the Da Vinci surgical robot. If we look at pop culture, if you like, this is a scene from a 1927 film where there's a robot depicted in the scene. Some of you may recognize it.
Computerized as a mechanized electronic aid for Earth voyagers engaged in astral expeditions. Computerized as a mechanized electronic aid for Earth voyagers.
Pausing that. Then we go on to Star Wars, and this is a robot from the 80s, from Hitchhiker's Guide to the Galaxy, for those that don't know. And then the robots sort of became more and more menacing as time went on, in Terminator again in the 80s and into the 90s and beyond. So in terms of robots and robotics, as I said before, they're everywhere. We see them in all facets of our lives. Some you may not recognize as being a robot, but a robot is something that can perform the job that it's programmed to do. So they can perform jobs instead of or as well as humans. And in some cases, they can actually do jobs that we're not suited to do or that are dangerous for humans to do, such as bomb disposals and that sort of thing. And the term robotic was actually introduced by Isaac Asimov in, I think, the 1940s in one of his novels. So would you want a robot to do your surgery? Well, surgical robotics has also been around for quite some time. And it started off with this device here in the top part of the screen. And this was just a voice activated, initially a foot pedal activated, but then a voice activated robotic arm, which controlled the camera that was used in minimally invasive surgeries. And so that was developed in the early 90s and approved for use in 1994. That was then superseded with this model in the middle, which was called the Zeus system. And again, you can see some robotic arms there, and one of them is holding the camera, which was from that previous ESOP system, and then using the control system here, you could then control where the arms were moving things around. And it was a fairly rudimentary system, and you can see that it's mounted on the bed there, and it made it quite a cumbersome and had very limited application. The Da Vinci robot was developed at around the same time, and interestingly, there were a whole lot of patent issues, and the way that the two companies resolved those patent issues was to merge in 2001, and that then resulted in the Zeus project being scrapped not long after that. The Da Vinci robot has had a number of different iterations over the last 20 years. And we have one of the newer model Da Vinci Xi systems, which has been around since 2014, with better HD 3D camera vision, better technology involved in the background of its processing. And so this is what the Da Vinci Xi system is made up of. So this is called the patient cart, and this is the arms that then hold the camera and the various instruments, and that gets wheeled into the bedside. This is the surgeon's console, and we sit at the console and operate that, and I'll show you how in a second. And then this vision cart just coordinates everything, and people can look at the vision that we're seeing through the surgeon console, and it can operate some of the other instrumentation and machinery that's used for surgery. Again, this is sort of how it all interacts. The surgeon sitting over here, the nursing staff and the bedside surgeon interacting with the patient cart, and then the techs and anaesthetic and other theatre staff interacting with the vision cart. So what's different from a robot robot assisting minimally invasive surgery to normal minimally invasive surgery? The main thing is that the instrumentation allows us to have a greater degree of freedom in how the instruments can be moved and manipulated. And so these things that look a bit like those camera gimbals are what we use to transmit our movements into the movements of the instruments. So we see that we can get the instrument to rotate or roll in the picture on the left. It obviously can go in and out according to where it's driven to in the on the arm, but also then we can do a yaw or a pitch movement and then a yaw movement. So it does have that sort of full range of motion that you can basically do this in those little finger grippers, and it will do that. It will mimic that at a slightly smaller scale on the inside of the patient. The other thing that the robot is programmed to do is to have this remote center, and what that does in particular for minimally invasive surgery is it means that the instrumentation rotates exactly or pivots on that point there. And so if you have that point at the skin in the belly operations or at the rib cage in thoracic operations, it minimizes the trauma to the surrounding tissues. And so that's another benefit of this sort of system over purely minimally invasive systems where surgeons or assistants are manipulating the long shafted instruments to perform the surgeries. So again, just looking at the different parts of the surgeon console, we sit at that big device I showed before, and our head goes into here to allow 3D vision. The camera itself has 2 cameras inside it so that we get that 3-dimensional vision. And there's a whole lot of sensors here to know when we're looking and when we're not, so that it only activates while the surgeon is inside the system. We use our fingers to manipulate the instrumentation, and this is just a short clip of that, and that whole system then allows us to do all of this. And so this is how I would manipulate the instrumentation inside the patient's chest cavity. And so it's like taking me from standing outside the patient to sitting inside the patient effectively with these instruments and the camera being right inside there. So again, I would ask, would you want a robot to perform your heart surgery? And given some of these features, I think yes. This was a picture that we took during my first case at St Vincent's, and so this is a lot of the stuff that was all involved. So this is the vision card over here. This is the patient card, and then tucked away in the back corner is me and the surgeon console. And we actually are very lucky in that we have 2 surgeon consoles, which allows for training and allows for this proctorship to occur. And this is what happens at the bedside. So the robot is all prepped and draped in a sterile fashion. This is the camera, and these are the other arms going into the patient. And so the main access is through a small incision in the side here. And then this guy's Dr. Cheng Yap. He was the bedside surgeon for some of my early cases. And so this is how the patient's set up. And then this is me sitting over after I've helped Dr. Yap set up the operation with my head in the console and trying to repair the mitral valve, which you can just see on the screen up there. For these early cases, I had Dr. Aubrey Almeida come across, and he's another surgeon in Melbourne who's had a vast experience with robotic heart surgery and in particular mitral valve surgery. And so it was invaluable teaching. And so just to reiterate some of the benefits and some of the reasons why robotic surgery is good from a surgical perspective and therefore translates is that we have better surgical ergonomics. So we're sitting doing the operation. We have 3-dimensional vision, which is magnified, and we're sitting inside, effectively sitting inside the heart. And so it gives us a very different perspective and better vision of the mitral valve and the pathology involved and what we need to get done. I just want to pass over to a patient of mine called Joe, who's given us a very nice video recommendation of his experiences with us.
Well, actually, I didn't notice at all there was something wrong with my heart. I was just progressing normally, and I had a change in doctors about 4 or 5 years ago, and this new doctor listened to my heartbeat and said, yeah, he heard a murmur. And that was it. That's the start of the process. Well, actually, it's a bit complicated. I had a cardiologist in Williamstown who wanted to operate and said that he had to crack my chest open. And I'm totally against having my chest cracked open to deal with the problem. So I went and saw a cardiologist at St Vincent's, Louise Criati. She monitored me for 2 years because she said there was no other symptoms. The only thing that I had was that I had a leaky valve. My heart size was good. My fitness was good. We had angiograms, etc., and they were good. Stress echoes, all good. So the only problem I had was the actual leaky heart, the leaky valve. Sorry, and so Louise then, and I said to her that if I have to have an operation, I want keyhole. That's the worst case scenario, keyhole. And so when she decided it was time, she found Andrew for me. Well, it was actually quite simple for me, from my end of it. All I did was attend a meeting with Andrew. We had a bit of a discussion of my situation and what I wanted. And I said to him, I don't want my chest cracked open. He said, no, we'll do keyhole. And then he said to me, would you be prepared to be involved in a robotics? And I said, absolutely. And that was the only meeting I had with him. And then he organised everything else after that, him and his team. I feel good. I feel fine. I'm playing soccer again. I'm doing a lot of manual labour. And I'm not feeling any problems other than my knee or my back or anything like that, but my heart's fine. Well, to be honest with you, no. I've spoken to Louise, my cardiologist, once since the operation, And basically, I think that was around November, December last year. And she just said, "Oh, I'll talk to you again in 12 months. And I don't take any tablets. I don't take any blood thinning, which is a fantastic result. Yeah, I don't have to have regular tests or checks, which is fantastic. Well, I mean, Louise was great. She was fantastic. She's been looking after me for what, 4 years now, 3 or 4 years, and she's very understanding. And she's always tried to accommodate what I wanted, and looked after my interests, which is fantastic. And put me on to Andrew. And Andrew was, well, it was easy with Andrew. Andrew and his team were great. I mean, I only saw him once before the operation. Then he organised everything, and it was so professional. I didn't want my chest smashed open to deal with my problem, and Andrew came up with the best solution ever. And robotics, I would recommend to anybody. The scarring is, there's no scarring pretty much on my body, and you know, I felt like nothing had happened other than just a minor operation. To be honest with you, I didn't feel like I've gone through a war. It was good. Just get checked on a regular basis, even though you might not think that you've got a problem, which was in my situation. It doesn't hurt to you know, talk to your doctor or talk to somebody about getting a check done on a regular, you know, annually or biannually, just to make sure that there's no complications. I've had a lot of friends that have had minor heart attacks or clots or whatever, and they didn't know that they were coming. So it's always good, especially at our age, to get checks.
All right, so some of the other types of procedures that the Da Vinci has been used for and can perform are in the colon area or in the abdominal area. The colon and colon surgery has been performed. Hernia operations can be performed, although it's not really that much of a difference from some of the other less invasive surgeries. Urology has been a big proponent of the robot, and they've been the highest users pretty much throughout the world. And it started with robotic prostate operations, which a number of you may know people who've had those surgeries. We also have gynecologists performing surgeries for benign and for malignant or cancerous conditions as well. And then in the cardiothoracic space, our lung surgeons have been doing a lot of work with building up their experience with lung resection surgeries, and also thymectomies for thymic cancers or for thymic problems. And then finally, the head and neck surgeons are also using the robot to allow surgery into the base of the skull and different parts of the nose. So it's a widespread sort of device that has a lot of application. So at St Vincent's Private, our robotic program in general started in 2018. And since that time, there's been over 1,000 cases performed across 7 surgical specialties, with 25 different surgeons, including myself, being accredited to use the robot. So it's getting a lot of use. We're one of the first, if not the first, public-private collaboration for teaching, and we actually have a urology accredited trainee at St Vincent's Private for the robotic program there. And then I've started the second cardiac surgical program in Victoria with, we've only done 5 cardiac cases so far, and they've all been mitral valve repairs. The other types of procedure that could be done with the robot is to harvest mammary arteries in certain types of bypass operations, but most of the time the robot has been used across the world for mitral valve repairs. And so that's all I really wanted to say today about that. And it was more to give information and try and show you some pictures of what it means to have robotic surgery, and also to give you Joe's perspective on what it meant for him. So thank you very much. I'm going to stop sharing my screen, and then I think we'll hand over to Andre to give his presentation. So you just got to unmute yourself there, Andre, and then.
Good.
You can hear me loud and clear?
Yes, we can hear you fine. Thanks, Andre.
Good, excellent. I'll go straight away. It's sort of from, I mean, that showcases beautifully some of the very innovative things being done here at St Vincent's Hospital. Mine's more of a sort of, if you like, day-to-day, what should I do? And the reason for doing this is as everyone will be very aware, some high-profile cases of people that have died suddenly of heart attacks. I'll explain exactly what a heart attack is, but you know, it often is portrayed in the media as sort of a lightning strike and something that happens very rarely. But as I'll point out, it's not so rare, and it's something that is one of our major health challenges, and something that particularly from middle age, we really should be thinking about what we can do to prevent. And also, given my interest in sort of sports, there'll be a little bit of a sports flavour throughout. And this article from the New York Times on the right, suggesting with the title "One Running Shoe in the Grave," I'm very keen to make the point that is often confused in the media, that athletes are putting themselves at risk, where there really is not any evidence at all to support that. It's really quite the opposite. So how do we prevent these things from happening? And firstly, before we even get to that, is it a problem? This is data from America looking at national college athletes who died suddenly under the age of 35. And there's a whole wagon wheel of potential causes here, some of which you'll be used to. Things like the purple one here, trauma, is mostly motor vehicle accidents, drugs, suicide, all of these things that we think about young people dying due to, whereas cardiovascular causes was more than any of those causes. So if you die at a young age, this is sort of top of the likelihood stakes. And if we look across all ages, again, sudden cardiac death or dying suddenly of a cardiac cause, usually a heart attack, is of a greater burden in terms of years of life lost, and also in terms of financial productivity, than a lot of the causes that you will hear about all the time. So in women at the top, lung cancer, breast cancer, colorectal cancer, yet sudden cardiac death is a greater cause of loss of life than any of those causes. And in men, where cardiac arrests are even more common than in women, then there's even a bigger difference between it versus these common causes like cancer. I'm suspecting that you're on the other side of your webcam thinking, hang on, this can't be right. I see ads on the television. I was at the Mother's Day March on Sunday, all of these things, and you're telling me that I'm more likely to die of a heart attack. And the answer to that is yes, that is correct. This is some data, and I give credit to one of the other junior cardiologists at St Vincent's, Dr. Liz Peratz, who's been working with me doing a PhD on a registry in Victoria. We call it the NDUCD registry, and we've been looking at every single case of cardiac arrest in Victoria, age 1 to 50. And this is data from the first 2 years of that registry. And what it shows is that when someone has an arrest out of hospital that's attended by the ambulance, about 55 to 60% of the time it is due to a cardiac cause. And this big red wedge that you can see going through the middle of this graph is labeled coronary. And what that means is that it's a cardiac arrest due to a blockage in one of the arteries that supplies blood to the heart. And particularly from around the age of 30, that starts to take off. And from around the age of 40, it really starts to take off. Although our registry goes to the age of 50, it becomes even more common in that middle to older age groups. So what is a heart attack? Because these terms are often confused in the media: an arrest, an arrhythmia, a heart attack. The real term heart attack refers to when there is a blockage in the heart arteries. And as this cartoon shows, the process there is that we develop fatty plaques in the arteries, little bits of what we call atherosclerosis, and that is common. For example, from the age of 50, about 2/3 of people will have some evidence on a CT scan of having some of these fatty plaques. What the big challenge for us, what the holy grail is in cardiology, is trying to work out which of those patients have an inflamed, what we call hot plaque, that then causes a clot to form which suddenly blocks off the artery. It is not a process of the narrowings being 50%, 55, 60, gradually increasing and then blocking off. It is a 30, 40% narrowing that all of a sudden, for reasons that we wish we understood better, all of a sudden that forms a clot and blocks very suddenly. You get chest pain, feel suddenly very fatigued, a number of different things which constitutes a heart attack. Now, from a heart attack, some of those patients then go on to have a sudden heart rhythm problem, a very fast heart rate, which stops the heart working properly, stops you having enough blood flow to the brain, and that's when you have an arrest, when you lose consciousness and collapse. So heart attack is a blockage of the artery, some of which go on to have a cardiac arrest. So given that heart attacks are the most common cause of cardiac arrest, how can we prevent a heart attack? And there we need to think about the modifiable and non-modifiable factors. And the reason for separating it like this is essentially modifiable means stuff I can do something about, and non-modifiable means I chose my wrong parents. You know, they're the things that are important because we look more closely, but you can't do much about being born male and having a family history. Now, when I say being born male, the reason I say that is that cardiac arrests occur males are 3 to 5 times more likely to have a cardiac arrest than women, and particularly in middle age. Some data from our registry, because I think it's very informative, and some of these facts are not well reported in the media. So from our registry, in the first 2 years, there were 1,300 cardiac arrests. So it's a very substantial number. And to give you an idea, that's 3 to 4 times more than people who die due to car accidents, for example. Of those, the main cause is heart attack or coronary artery disease. Now, really importantly, in those people who have a heart attack, middle-aged or younger, more than 1/3 of those people have no risk factors at all. They don't have high blood pressure, they don't have high cholesterol, none of those things. It occurred very much out of the blue. And in 77%, they had no symptoms of heart disease. So this is the major challenge, is trying to identify people who are at risk when we have very limited ways of identifying those people. Now, the other thing we found from our registry is that people are more likely to have a cardiac arrest when they're exerting themselves, when they're putting their heart under pressure. But I'll come back to that fact because it's not as simple as easily reported. So what can we do? Now, one of the calls to action after the Shane Warne tragedy and these recent events was go and see your doctor and have a heart check. And I would strongly advocate the same. It's important, but it's also important that you realise the limitations. So we recommend from the age of 45 or from the age of 30, if you're of Aboriginal or Torres Strait Islander descent, and to see your local doctor or your cardiologist and have a heart check. Now, what that heart check comprises is a check of your blood pressure, of your cholesterol, of your blood sugar, and in addition to information about your family history and other lifestyle factors. And we can put all of those into any one of a number of phone apps or computer-based apps and work out whether people are low risk, medium risk, or high risk. And that can define what we can do in terms of further tests and preventive therapies. But here is the challenge, as I intimated before. The majority of people who have a heart attack who are middle-aged are actually found by us to be low risk, and we would ordinarily sort of reassure them. So this is where we need to get better. I know this is a Catholic hospital, but I'm just going to make this really blunt, that we're pretty crap at identifying those people who are going to have a heart attack. Now, please, I am not saying, therefore, don't worry about getting a heart check, because this is a common condition and we need to do everything we can to prevent people having a heart attack. But at the same time, there is a real need for research, innovation, and better approaches so that we can get better at identifying who's going to have a heart attack. So here are some of the things that extend beyond just a phone app that may have the ability to sharpen the pencil and better identify people who might have, who might be at risk of having a heart attack. Stress tests I'm going to mention and then dismiss. Then importantly, a discussion around CT-based risk predictors and genetic testing that's on the horizon. Now, stress testing has no role at all in identifying people at risk of a heart attack who have no symptoms. The only useful information we glean from a stress test is how fit you are, and that is the strongest predictor of your risk. But again, it really works on just averages rather than identifying a risk in the individual. And in reality, I can work out whether someone's fit just by asking them a few questions. Bottom line, don't go to your doctor and ask for a stress test to see if you're going to have a heart attack. On the other hand, CT scanning, and particularly a very simple CT test called coronary artery calcium score, can be useful in refining our risk prediction. Now, we do not have any tests that are perfect. We can't do a test to tell you whether you're going to have a heart attack or not, but we can increase our accuracy in sort of the prediction. And what this graph here shows is that along the bottom, this 0 RF, 1 RF, that's how many risk factors you have. And as your risk factors increase, the more likely you are to die of a heart attack. What these green, yellow, red show is the increase in coronary artery calcium. And if you have a coronary artery calcium over 100, then you start to have a pretty high risk of a heart attack, even when you don't have risk factors or few or no risk factors. So this is a group that we wouldn't normally identify on our apps, that we can identify by doing this quite simple test. And therefore we can institute preventive therapies in people that we wouldn't have thought were at higher risk. Now, one of the other tools on the horizon is this idea of doing a genetic test, what we call a polygenic risk score. So we look at a whole lot of different traits in your genes, and we can divide people up into high, medium, or low risk. And again, that can help us to sharpen the pencil. So these are not binary tests. They don't tell you you are going to have a heart attack, but they increase, instead of us saying your risk is 5% over 10 years, they might tell us that your risk is 20% over 10 years, and therefore cross a threshold where some of our preventive therapies really have some use and clout. That brings me to what can we do? So what can we do if we find that your risk is higher? Then really the most important thing we should do is reinforcing all of the important behavioral things: exercise, physical activity. And in fact, now we divide things up into doing more exercise, but also avoiding sitting time and sedentary behavior, which is an independent risk. We need to focus on a good diet, particularly a Mediterranean diet. We can discuss that later if people have questions. Try to remove stress, often easier said than done. Treat high blood pressure and to treat our cholesterol. Or in fact, if you're at higher risk, there's very good evidence to support taking a statin cholesterol tablet, even if your cholesterol is normal, because even though it reduces the cholesterol, its main job is to reduce the inflammation in the arteries and to make that fatty plaque less likely to be hot, inflamed, and clot off. And statins reduce the risk of a heart attack by about 25 to 30%. So if your risk is high, then you get a good bang for the buck. If your risk is low, then any benefit from a statin is very small. Now, how much exercise should I do? And this is a very useful graph. So this shows fitness, but also sort of how much exercise you do along the bottom here. And this is your risk of dying. And really the point here is that as you go from doing very little exercise and being unfit through to being a bit fit, through to being moderate fit, you get a massive reduction in your risk of heart attack. Whereas if you go from being really fit to super fit, then your reduction is pretty small, diminishing returns. I'm not saying don't go out and do as much exercise as you like, but the other end is even more important. That is, if you're not doing any, then get started and get started today. Now, I promised that I'd try to clarify some of the confusion that is sometimes out there. And one of those relates to this story from way back in the 80s of Jim Fixx, who wrote the complete book of running and was an avid runner and who died at the age of 52. I'm not quite sure what it is about the year 52 because it also has been the exact age where we've had some recent tragedies in Australia. Nonetheless, this was his story. But if you look back in his history, 15 years before that, he was a very heavy smoker, he was obese, and he had an extremely strong family history. That we always look for an excuse, and he may well have had a heart attack even without those risk factors. But my point here is that how you behave today doesn't necessarily erase all of the issues in the past. It's also really important to talk about the exercise paradox, because as I explained before, the risk of having a heart attack increases when you exercise. And this graph here is meant to explain, this is, for example, someone getting up, run for the bus, play a game of squash at lunchtime, and each of those constitutes a really substantial increase in the risk of heart attack every time you're doing physical activity. And that risk is massive if you're not used to doing exercise. Whereas if you do regular exercise, each bout of exercise constitutes only a very small risk. So there's the paradox, is that you have to exercise regularly to make exercise safe. What that also means is that if you're starting a new exercise program, don't go like a bull at a gate, just increase gradually, both in terms of the duration and the intensity of the exercise. And the final 2 points I want to make, and these are really key, is even though I've talked about coronary calcium CT scans as a way of better identifying your risk, these graphs, and you only need to, this is 5, 15 and 25 years after the scan. Perhaps let's all just focus on this 25 years after the scan. The red line is people who have lots of calcium in the arteries through to moderate amounts, small amounts, and none. And so the risk of having a heart attack increases with the more calcium you have. But the fitter you are, the lower that risk. So that if you've got a lot of calcium, your risk is about the same as someone with very little calcium who's unfit. So it just shows how important it is to do regular exercise and stay fit. And also, if you do get a coronary calcium score and it's 400, don't stop exercising. That is part of your treatment. I've seen far too many patients referred from GPs with after CT scans and being told to stop exercising. That is not correct advice. So it shows how important fitness is. And this shows exactly the same thing with the genetic risk. So as I said before, you can do these polygenic risk scores. All that these complex graphs show, so the red is people who have a bad lifestyle and the blue is people who have a good lifestyle. And if you have a high genetic risk, your risk is about the same as someone who has a low genetic risk, but who has a favorable lifestyle. So basically, putting those two things together, if you have a good diet and you exercise regularly, you are not immune from having a heart attack, but you are making yourself the very lowest risk that you can be. You can't change your genes. It's hard to change the calcium in your arteries, but you can change your diet. You can look after your blood pressure. You can regularly exercise, and you can reduce your own risk of having a heart attack. a little bit in terms of, because one of the questions is, if we do these scans, does it motivate people to change? And it's an interesting question. There's still some data coming out on this, but it's perhaps a little bit more disappointing than we'd think. It's a bit like in the days of where people would show people the X-ray evidence of their smoking damage and it wouldn't get them to smoke. Seeing your results are not necessarily, or at least on their own, are not just the motivation that we need. Now, a really important thing, because we see this all the time, is that people have all these tests done. They have a CT scan, it shows some narrowing in the arteries, and then people go on to have surgery or to have a stent put in the arteries to open up the narrowing. There is absolutely no evidence in someone who does not have chest pain that opening up the artery reduces the risk of having a heart attack. As I said right at the beginning, a heart attack is this difficult thing to anticipate, which is when a plaque of any degree of narrowing suddenly clots off. And a stent and surgery do not fix that. The thing that prevents it, at least to some extent, is a favourable lifestyle and/or statin medications. So, in summary, when we're trying to prevent heart attacks, attention to risk factors, age, cholesterol, blood pressure, diabetes, and smoking can help identify those who are at risk and are the things that we can focus on to prevent some people from having a heart attack. The big challenge, and where we need to do a lot more research, given that this is a common problem, is that we need better ways of identifying who's at risk of having a heart attack in low-risk individuals. In those people, exercise testing adds nothing at all. CT coronary scans, including calcium score, can help a bit. Genetics, not really readily available at the moment, but they might be a test that help a bit as well. And adding all of these things together, we might have a slightly sharper pencil so that we can start preventive therapies in the right people. And then we need to pay a lot of attention to all of the lifestyle factors, and indeed they're things that we should be doing even without all of these tests. So this is my research team on the left. I just want to focus in the, if you can see my arrow, but dressed in black, and right in the middle here is Liz Peratz, who's done a heap of the work on cardiac arrests and heart attacks. And on the right of the screen here is a website, nationalsportscardiology.com, which is a service that we have here at St Vincent's Hospital. And we have a range of podcasts, one that was released not long after the tragedy of Shane Warne that discusses all of these things in detail. But we also have podcasts with some sporting celebrities about heart rhythm problems and various different things. And if you're interested, I'd certainly, it's a free Apple or whichever podcast you like, and you can have a listen to those at your leisure. Thank you very much.
Great, thank you, Andre, and might invite Andrew back as well. Thank you, Andrew, and we'll go through some questions. So I know quite a few of you wrote some questions when you registered, so we'll go through some of them. If you want to ask a question now, if you just press the Q&A button at the bottom of the screen there and type in your question, hopefully we'll have time to get them to Andre and Andrew. Quite a few people did have, questions about their family histories, which you sort of covered to some degree. But one of them from Christine is there any particular diet you would recommend to optimise heart health other than a healthy one?
Yeah, so diet, and I didn't speak enough about diet, and diet is interesting because it's a bit of a swinging pendulum, or you get sort of the diet of the month or the diet of the year. The thing that has remained true over decades is the benefits of, from the tree to the plate. In other words, fresh fruit and vegetables, a diet that is rich in oils that are non-animal based. So olive oils, fish oils are in fact good, and vegetable oils, nuts. So a Mediterranean style diet is a very good place to start.
Great, thank you. One from Susan in our Q&A online there. She says, I get chest pains because of GORD. How will I know if it's related to heart problems?
It's a good question. So GORD is gastroesophageal reflux disease. So essentially, if I even broaden this further and say, how do I know if that pain in my chest is due to narrowings in my arteries or angina? And that's a little bit, so the talk that I gave was very much about looking for heart disease in people that have no symptoms. And I should have made the point that if you have any awareness of chest pains, then you should get it checked out. And we have a range of tests that can accurately identify whether that pain is due to the heart. And that is where exercise tests can be very useful, and CT tests can be very useful, because that is where we are looking for narrowings in the arteries, and they can be fixed with surgery and they can get rid of that pain. So it is a bit different, although related to the talk of screening in asymptomatic individuals. But if you have chest pain, please go and see your local doctor. Please come and see your cardiologist. And we've got a range of tests that will identify what the cause is.
Great. And Will's got a bit of a question about the calcium score test. So without having a calcium score test and thinking proactively, what can we do diet-wise to reduce our calcium score?
Yes, so as in that one of the graphs I showed was that as you have increasing risk factors, the higher on average the calcium score is. Calcium score has a degree to which it's affected by the things we do, and then probably genetics or something. There's just people that do everything right and are unlucky enough to have coronary disease. But in terms of the question, what can we do? Then all of those things I mentioned, regular exercise, good diet, treatment of blood pressure and diabetes, all of those things make it less likely that you'll have high coronary calcium.
Okay. I think we're getting close to 1 o'clock. I'll do maybe one more quick question from Anonymous, who's asking, is running marathons good or bad for your heart?
Yeah, so running marathons is good for your heart, because doing any form of exercise is good for your heart. And it's a really good question, because I think it's almost the thing that's most confused in the media. What that graph that I showed where the risk reduces with exercise and then plateaus, what I can say is that if you do, half an hour of moderate exercise, or perhaps an hour of moderate exercise a day, then you are getting your maximum benefit. If you then decide to run marathons or do whatever, then it's for the love of it. And there's not a great deal of additional benefit in terms of prevention, but you are not doing yourself any harm. Definitely not doing yourself. In my patient groups, I'm worried about the person sitting on the couch, not the person running marathons. If you are going into marathons, it is a good opportunity to think about prevention, going and getting your blood pressure and all of those things checked, because just because you run marathons doesn't mean that that you don't have a risk of a heart attack. But definitely run your marathons, get into the training gradually and consistently, and good luck.
Great, thank you, Andre. Well, I'll pass over to Sue now.
Thank you, Robert. That was fantastic, Andre and Andrew. My son's competing in a marathon on Saturday, so I will let him know that he's no better than I am with my 1 hour's exercise a day.
Good.
Thank you to everyone for participating in today's webinar. On behalf of the Foundation, a personal thank you to both Andre and Andrew for their captivating and informative presentations. I think it's great to just keep getting those messages out there. If you'd like to watch today's webinar again or share it with families or friends who weren't able to attend, we'll send you the link to the recording later this week. And if you enjoyed the webinar, we'd be extremely grateful if you consider making a donation to support our work here at the Foundation. The last time I had to buy a Da Vinci robot, I think it was 2.8 million, Andrew. So, you know,
I think it's more than that now, Sue.
I think it probably is, but I did get the opportunity to play with it as well. I think I operated on a tumor. Don't worry, it was all pretend. But, it is fascinating to see the role that robotics are going to play in the future. And it's also to get good health messages from Andre. So again, thank you both very, very much. And thank you to all who participated today. Thank you. Goodbye.